I'm so excited to take the time to introduce to you right now our panelists this afternoon, starting with Kassandra Frederique, who is the Executive Director of the Drug Policy Alliance, a national nonprofit that works to end the war on drugs, which has disproportionately harmed Black, Latinx, Indigenous, immigrant, and LGBT communities, and build alternatives grounded in science, compassion, health, and human rights. During her time at DPA, she has built and led innovative campaigns around policing, the overdose crisis, and marijuana legalization, each with a consistent racial justice. Her advocacy and all of the DPA's work lies at the intersection of health, equity, autonomy, and justice. I am also very excited to have Claire Zagorski joining us today, who is the program coordinator for the Pharmacy Addictions Research and Medicine program at the University of Texas at Austin. She earned a bachelor's degree at UT Austin and a master's at the University of North Texas Health Science Center, and has practiced clinically as a paramedic in multiple treatment settings, including as a member of the Austin Harm Reduction Coalition. She founded Longhorn Stop the Bleed and is committed to supporting healthcare professionals who seek to integrate harm reduction principles in their practice. Also joining us is Nyabingi Kuti, the director of the LA Harm Reduction Network, whose goal is to expand and enhance access to harm reduction resources in the areas of mental health, substance use disorder, and community violence. He has done policy advocacy for Tarzana Treatment Centers, the DPA, the LA County Department of Mental Health, and other organizations. He has also done radio and public presentations on the drug overdose epidemic, expanding access to addiction treatment for the homeless and reentry communities and community violence. He is also a member of the Progressive Caucus and the California Democratic Party. Lastly, I'm super excited for our moderator for today's session, Tamika Jackson, who is a proud graduate of the Alabama State University, a historical Black university in the South. She is a certified experiential specialist working in the South to develop pro-Black and equitably sustainable organizations. Tamika has worked in social and stigmatized health topics for the past 20 plus years in sex education, domestic violence, sexual assault, suicide prevention, parenting education, and most recently, reproductive justice with a focus on abortion referrals. Currently a member of the National Harm Reduction Coalition HEP Connect team, in the role of regional director, she is tasked with leading and providing strategic support for the HEP Connect initiative to reduce hepatitis C through the expansion of harm reduction services. With that, Tamika, I'm going to turn it over to you. I'm very excited to have everybody with me, and please let me know if you need anything. Thank you.
Sure. Thank you so much, Rachel. Hello, everyone. Again, my name is Tamika Jackson, and I will be kind of, how can I say it? I like to say guiding the ship somewhere with our conversation today. It is so great to be here with all of you. The first thing we want to jump into is actually shaping the space for the conversation and grounding it with the actual principles of harm reduction. So I'm going to actually, if I can, share my screen to go over just those things that we outlined at the National Harm Reduction Coalition. We are, of course, a national organization, but we have folks that are doing this work everywhere. So we want to make sure we ground this work in discussing our principles of harm reduction. Just give me 1 second. There. And can y'all let me know if you actually see it? Do y'all see my screen? Okay, good. Thank you so much. All right, so the principles of harm reduction. The principles of harm reduction that are outlined or that guides the National Harm Reduction work is health and dignity, participant-centered services, participant involvement, participant autonomy, sociocultural factors, and pragmatism and realism. And I'm just going to ask my panel to actually expound upon these if they'd like to. So the first one, of course, here, health and dignity, establishes quality of individual and community life and well-being, as the criteria for successful interventions and policy. Did anyone want to add some practical knowledge or experience around why health and dignity is something that we make sure we center first as a harm reduction principle?
I can comment on that.
Thank you.
Yeah, I think that one area of concern for me is high relapse rates amongst users. And I think that health and dignity, I think dignity plays a real big part in relapsing. A lot of times the loss of dignity is a trigger for relapse. Different things happen in people's lives. So I think that looking at the relapse rate, and the organizations that I work for that do treatment, I don't think that they look at ways to better to lower those relapse rates. So I think that that's one issue that is one issue I'm concerned about.
Thank you.
I'd also add that I think the point that was just made works, and also the fact that I think there's an idea that people have to crawl and beg to get help, and they have to crawl and beg to get resources, and that in order for them to get the things that they actually need, that they have to prove to providers that they want it. And I think one of the key principles of harm reduction is that your presence is enough of a commitment for the things that you want. You don't always have to be nice. You don't always have to say please and thank you. You don't have to kiss the butt of the provider. Your presence is a presence, right? And that is enough for us to figure out how to give you quality support, and that even in your most trying and sometimes complicated times, that it is worth our service providers' time to support you.
Thanks, Cassandra. Claire, did you want to jump in here?
I think that was put really, really well. The major thing I might add, just to kind of grow upon what Kassandra just offered, is that healthcare is always, always, always a human right. But for complicated reasons, layered reasons, we tend to try to withhold this from people who we see as other and beneath somehow. And people who use drugs are a major class of that. And, there isn't a day that goes by that I don't think we all hear about examples of people who use drugs who are dehumanized and degraded within a healthcare space. And while there are so many things that layer into substance use, health issues are a major one, and certainly one that dominates a lot of discussion. For me, coming from a healthcare background too, this is something that's very forefront in my mind. And a lot of what we see and discuss and try to shed some light on, I think, for healthcare providers, is that this sense of the removal of dignity from their patients or clients or peers who may use drugs is something that's baked in to their training, to their upbringing in American society even. So it's a very important thing to continuously remind people of, because it's so easy, I think, if you don't actively think of this, to just keep falling back into this trap.
So one of the things we also make sure we point out in the dignity of a person receiving services is exactly what Cassandra said, making sure people understand that we are here to support them just because they exist, and not because we are trying to balance, do we believe if they are worthy of this service or not? One thing that I wanted to make sure that I add. So participant-centered services, of course, that is a principle because we want to make sure when we are offering services to people that they actually need, that we're not offering things that no one asks for, which is one of the things we think about all the time, and making sure we ask folks in communities what they need instead of making assumptions, right? Instead of making assumptions. And because of time, I'm going to go through the rest of these, and y'all let me know if you want to add something. Participant involvement. One of our principles at the National Harm Reduction Coalition is that we honor the experience of those. We honor them in ways that looks like a lot of different things. And one of those is money. We pay people for their experience if they're expounding upon things that have become an expertise for them. We pay them for their time. We are very mindful of exploitation, right? Deciding that a person should tell their story a million times just for the extra work. So we're mindful of that, but a principle is we definitely involve participants in the structure of creating services that actually make sense for people to receive. Participant autonomy, which of course leads into health and dignity as well. We want folks to be empowered and understand that of course they are worthy because they exist. And one of the things that I've found in this work is meeting so many folks that don't know that their existence is enough, right? That their existence is empowering and what that word autonomy actually means. So we talk about that all of the time in the work that we're doing and the way that we strategically plan the work that we're doing. Sociocultural factors. Now, with this one, we think about where a person actually could be in the world, right? Receiving these services and who are the folks that are saying that they want to offer those services. So I'll read what we have on the slide just because it offers a little bit more context, but it says recognizes that the realities of various social inequalities affect both people's vulnerability to and capacity for effectively dealing with potential harm. Last but not least is pragmatic and realistic. So we want to think of things that actually make sense for folks and not have to get in the weeds for services. Here, the verbiage on the slide does not attempt to minimize or ignore the real and tragic harm and danger associated with illicit drug use or other risk behaviors, right? So we are thinking about how we are realistically supporting folks and also respecting their autonomy in the work that we do. So these are the principles of harm reduction. Did anyone want to add anything? I'm gonna went through those last few so we can make sure we get to our Q&A section, but we wanted to make sure we started with the principles of harm reduction so we can ground the space in this is what we seek out to do in our work, right? That it is people-driven, a response to people work. Did anybody want to add anything?
I just wanted to add really quickly is that that this work is in concert to broader community, right? So I find that oftentimes harm reduction has taken a while for people to understand it, and now some people are understanding it, and some people are trying to weaponize it. And that part of the principle of harm reduction is that these policies exist because it's for the greater good, not only of the person that's using drugs, but for broader society, right? And so oftentimes people think that harm reduction principles are in direct conflict with broader society, and that our existence of the framework and the philosophy and the politic of harm reduction is actually one that adds to broader society, that this is not happening in a vacuum and only for certain groups of people. And so I thought that would be important for us to really reinforce in the principle of pragmatism and realism is that this is about modeling ways that we should be treating all people everywhere, right? Regardless of how they show up in the world.
Thanks, Kassandra. And we also make sure we say that this is radical love because it's what it's supposed to look like to love a person, right? With all of the extra stuff that we like to make sure that we add again to suggest if a person is worthy enough, right? To suggest if a person is worthy enough. I have one more slide I just wanted to add, just thinking about what you mentioned. Thank you so much. But so these are some of the harm reduction services that we see across the nation at NHRC. This is not an exhaustive list. This is just some of the things that we identify as harm reduction services because I would hear in my work all the time around let's use the seatbelt analogy, right? So a seatbelt is harm reduction, but what we're actually thinking about is a person's ability to choose those things for themselves when it comes to how they care for themselves, right? And specifically talking about drug use, not a seatbelt, right? So syringe access and disposal, safer drug use and safer drug use supplies, safer sex materials, overdose prevention, medication for opioid use disorder, referrals, housing first, drop-in centers, and safer consumption sites. So these are the things that we make sure that we are supporting. This is harm reduction. Of course, there are other ways or other things that we can add to this list. I would say right now with the reproductive justice conversation and Roe v. Wade, we need to identify abortion as a way, as harm reduction, right? So we could keep adding, but these are some of the things that NHRC makes sure that we center when it comes to harm reduction services. Just wanted to share that. So moving along, folks, I wanted to jump into, actually a question that I have for y'all that's not necessarily a discussion prompt, but I wanted to ask specifically around or how harm reduction fits into the medical and chronic disease healthcare models. Now, that's one of those questions that I think is important for us to note, but I'm going to ask, of course, the panel, can you guys add any context around harm reduction, chronic disease, medical healthcare models?
I think that's one that I can jump in on, if that's okay. So I do come from a healthcare background as a paramedic. And one of the things that I find there's a lot of conflict with and resistance to understanding is this idea of how any measure of substance use can possibly be something that makes sense within a care plan that's developed by a physician or a nurse. And it's very simplistic, but one of the things that I try to kind of coax people to consider is, well, what if you had a patient who had an especially poor diet and they had lab values that were in bad shape, and you believed as a clinician that that was linked to their diet? Would you consider it a win if you got them to make measured changes that they were able to stick with versus telling them you need to go on this really restrictive, quote, pure diet that's exactly like it looks in the textbook, even if you knew that they probably couldn't stick with it for more than a week or two. And that's kind of the baseline that I have to bring some people to, because there's just so little kind of common ground baked into the way that we teach and educate physicians, nurses, and other people in healthcare. So I find this to be a kind of a powerful toehold for talking about this, because everyone does understand the chronic disease model, that, it's something that's going to follow this patient for many years, it may be their entire life, maybe not, but, and it's very likely affected by other things outside of this person's control. So perhaps this person lives in a food desert. Like if you want to go back to the diet model, perhaps there's just simply restrictions built into money, their ability to find certain foods, their ability to find time in the day to prepare certain, et cetera, et cetera. And that kind of gets out and bigger the more you kind of poke at it. But I think that this is a really kind of a fruitful toehold, to kind of keep going back to that term, to help people within healthcare understand that going into this really like binary total sobriety versus complete, like, no harm reduction whatsoever is not a very useful way to approach healthcare. It's not a very useful way to approach the care of your patient. So it's one of these things that's a little frustrating, because it can be a very kind of an insular community that tends to reinforce one another over and over again into thinking certain ways. But I think that's a fantastic way to start the conversation, that in both the case of a lot of the chronic diseases that we deal with in the US and substance use, a lot of the issues that help our patients get better or keep our patients sicker are rooted in things that may not be within their immediate control. I'd love to hear if anyone else has things to add on to that. I don't want to be the only
Hop in just
talker.
real quick.
Yeah.
Claire, thank you so much. For those of you who were here because track C was having some technical difficulties, we are up and running. Not that I want you to leave, but just so you know that track C is up and going if you need to hop over there. So thank you. And I'll turn it back to you, Tamika.
Thank you. Okay. Did anyone else wanted to add to what Claire mentioned, or?
Yeah, I wanted to jump in on that. I think that abstinence-based, I think Claire touched on the abstinence-based approaches still being used in treatment. I think that, that works for some people, but it doesn't work for all people. And some of the treatment providers that I've worked for, they claim that they are harm reduction based. But when you look at their programs, they are not, they're abstinence based. So, and then also I've worked for treatment providers that some of the employees just didn't need to be in harm reduction. They were sicker, mentally sicker than the people that we were treating. So, and then policy, government policy around harm reduction is just terrible. I mean, methadone access is still, the policy is 30 years old. The fight around getting safe consumption sites approved nationally has been just a very tough battle. We're in it here in California, and I know we're making progress, but it's like a perfect storm, and we're in the middle of a fentanyl epidemic, and these policies and these structures that are in harm reduction that actually drive, I think the treatment providers and government are the drivers of addiction treatment and of getting the proper resources for people that are suffering from this illness. And they're not doing a good job at it.
Thank you. Kassandra, did you want to add to that? Yes, no?
I mean, I think the biggest things that we can see in the medical and chronic and issues of chronicity is that a lot of times those patients don't have autonomy, and their health and dignity is often challenged because of things like prescription bans or the stoppages that are happening. We're seeing a real uprising among people who navigate chronic pain because a lot of these principles are not placed and are not what they experience, because the medical model is not one of harm reduction. The medical model to me, is based on control and containment. And that brings it to a lot of what people need, which is pretty much runs counter to the principles of harm reduction. And so I think one of the things that we've seen in the advocacy around drug policy and harm reduction, especially around the opioid crisis or opioid situation that we're navigating, is that chronic pain patients are like, you can't just have harm reduction on this side. Like, what is the harm reduction on this side, right? And how do we build a continuum of all the people who use opioids? And so I think it is an area in which there's a deep need for cross-pollination around how structures are set up. But I think part of the struggle is that harm reduction was created as a shadow infrastructure for people that the regular system wasn't dealing with. Those folks are not in a shadow system. They are in the system. So the system is working the way that it is supposed to. And so it's a conversation about how much work should we be doing to reduce the harms associated in that structure as we continue to build an alternative healthcare system. Because I, for one, do not believe that the underpinnings of the healthcare system that we navigate now are ever going to fully address the needs of people that are not white landowning men. And so how do we create an alternative health system that's based on the principles of harm reduction that will benefit people who use drugs, but also people that are navigating chronic situations?
Thank you. So you brought up something that I wanted to make sure what kind of jumps into one of the next things we're going to talk about is specifically harm reduction, right? The work that was actually being done, that grassroots work was to take care of the folks that could not be in those systems, right? Did not necessarily fit in those systems, was definitely, the system wasn't created for in the first place, right? But there's several intersections, right, to the work that we do in harm reduction. And then you brought up another word that I think is important to this point around policies. My next concept of thought I want y'all to think about is how systemic racism and inequitable drug policy leads to the stigma of addiction and people who use drugs. Now, I will say that, I was going to look at you, Kassandra, because I'm not trying to call you out. I'm just leaning into your expertise. But we don't always have that conversation because we want to make sure when we talk about racism, right? And I want folks to know that I am actually in the South, born and raised, lived in the South. So yes, it is a constant conversation that has to be had because it's a constant around surviving and living, right? Here in the South, racism itself, but systemic racism, right? And when we talk about drug policies, how did those things create what we see now when it comes to the stigma of addiction and people who use drugs?
I refer to our drug policies in the US as a master class of white supremacy policymaking. Because our drug policies were based on racial control. Every single drug that was criminalized, they used a group of people who were not white as a way to demonize them. And they also went out of their way to demonize the drugs that were associated with people who were not white. So, when Richard Nixon declares the war on drugs, this version of the war on drugs in 1971, we already had 100 years of evidence that the drug war was racist. Because in the 1870s, when they banned opium, it was against Chinese migrants. And the thing about how they banned opium was not all opium, it was smokable opium, which was the opium that was associated with Chinese folks, right? Not the opium that white women were getting prescribed by their doctors, right? And so there's always been a line of demarcation around how drug policies should be impacted. So if you think about why in the United States we call cannabis marijuana, it's because in the Southwest, Mexicans referred to cannabis as marijuana, right? Like that was the Spanish word for it. If you look at the crack cocaine disparity, right? They made the punishment for crack more severe than that of cocaine because cocaine is a drug that is used by resource white folks. And so I think if we chart out even the way that we talk about drugs, I mean, if we talk about fentanyl, right? And a few years ago, the conversation about fentanyl was all about Mexicans and Chinese labs, right? And so there's always been a connection between folks that are not white and drugs and how that really shapes the media conversation, which only bolsters the policymaking. So if you think about in 2015, when Maine Governor LePage talks about the growing overdose crisis that they were facing in Maine, he's like, We have an issue because Tyrone and Jay Smooth keep coming up here and impregnating our white women and addicting them to opiates, right? Like, that is not about drugs, right? That's about using drugs as a reason to create draconian policies that systematically target groups of people. If we look at even the way that this country has navigated the overdose crisis, the perception that the overdose crisis was hitting white people may not have changed policies, but it did change conversation. But as the overdose crisis is moving into a direction where we're seeing Black and Indigenous people being disproportionately impacted, we're seeing the rhetoric around personal responsibility and urban decay really real in our space, where people are feeling like we've gone too far and that we actually need to pull back. And so you actually cannot have a conversation about race, and you can't have a conversation about drugs without systematic racism, even when we're talking about how the drug war has impacted white rural communities. Because race is still in the center of that conversation, because white people are also racialized. And their racialization may show up differently based on class, but therein lies the conversation where we cannot do drug policy divorced from a real commitment to racial equity and racial justice, because we will continue to pass policies that lead to the ending of the drug war for white people, and then people who are not white will still be under the pressure and the gears of racist drug war policies. And that's what you see with cannabis regulation, where you're seeing we have legalized cannabis in places around this country, and cannabis arrests are still disproportionately impacting Black folks. You're seeing that when we talk about the increasing of access of resources for people who use drugs, but you see who's actually receiving these harm reduction services. Where are these harm reduction services being placed, right? The oversaturation in communities of color, which our harm reductionists really get upset when we talk about, but it's actually true. Like, let's stop gaslighting communities of color and stop acting as if not all the methadone clinics and not all the syringe exchanges are in their neighborhoods. And like the Upper East Side, where these people are also popping these drugs, they don't have to go, they don't have those services in their neighborhoods because their NIMBY is strong enough to push it back, and nobody listens to people of color when they try to push back on something. And, you know, I fight against these Black folks. Like, no, you do need this methadone clinic. No, you do need this overdose prevention center. And their conversation about like, but why do we have all of them, is a real conversation that we have to engage with, and our side doesn't do very well. But there are multiple examples of the ways that systematic racism and drug policy are hand in hand and are part and parcel of the same conversation.
And I want to talk about the role that Black policymakers play in this crisis. Big Pharma is very influential in the Democratic and Republican parties. And under Obama, opioid monitoring was relaxed. He signed the bill relaxing opioid monitoring. So I think that it's bigger than a race problem. I think it's an institutional, governmental policy that shows the effect of corporations on health, corporate dollars. I mean, we see that in war, healthcare during the COVID epidemic. We saw who was most impacted by COVID. Were people of color and people with poor healthcare benefits. So yeah, I think that it's beyond race, and that you know, this Black policymakers were very instrumental in starting this so-called war on drugs back in the 80s during the crack epidemic, and we're still being affected by a lot of these policies. So one of the things that I'm doing here in Los Angeles, I work a lot with some of the Black electeds that are more on the progressive side, and Some of them seem to just lack education. Like I said, we were working on establishing safe consumption sites where there's a bill in place. I know New York is leading that, has already done that. So we're looking at that as a model. But some electives, when you say safe consumption sites, they say, oh, shooting galleries. And some of them were Black that were thinking like that. And, when you educate them and show them about different models in Europe and Canada that are working, that seems to change their view if you can get their ear.
Thank you. So I want to make sure that, just conceptually, just thinking about how, well, again, in the South. So where it is harm reduction is a horse of another color, right? Like we have policy, stigma is rampant, right? There is a negative thought on every community. There is a negative thought on every gender. There is a negative thought or the way that we treat people in general in the South, which makes harm reduction pretty difficult because of the way that systems of oppression have already been in place, right? Again, talking about the history of the South. So when we see, or the way that harm reduction is identified here is it is criminalized. It is immediately criminalized. Folks are asked immediately about what is the reason you're doing this work. We have the bootstraps conversation, which drives me bananas. People need to pull themselves up by their bootstraps. Everything is a choice. What does it look like? So I think it's really important to make sure that folks understand that when we talk about areas where it is definitely really difficult because of the stigma that surrounds everything that a person can do in their life. The South we have some issues, y'all. It's pretty difficult to actually do this work here. And if I'm being honest, the work does not look like the way that the panel is set up on this call. Even at the National Harm Reduction Coalition, it is not as diverse as folks would like to think that we are, but it is because the communities that receive funding does not look like myself at all. So the folks that actually that's receiving funds, there are areas, California specifically, right? New York specifically, we're talking about work that gets done. I actually lead a grant initiative that supports work in Appalachia, where hepatitis C, when we talk about the chronic disease model, has devoured areas, right? And the way that we're trying to aid that is through harm reduction work. But because we have to work around the fact that people have placed thoughts on the worthiness of people who use drugs, stigma is a constant battle. So moving into the conversation of stigma, I'm going to ask y'all just to discuss really quickly when it comes to stigma and harm reduction, right? What do you think, or what can you describe are some of the general ideas? What are the general sayings, thoughts? What are those things that we're constantly having to educate folks around when it comes to harm reduction and stigma?
I'll go ahead and jump in. I think one of the biggest things that I get is this complete lack of willingness to empathize with others. And I think that's what a lot of it really boils down to. It's that and this really this intense need to try to position yourself as better than someone else, no matter the cost. So I hear a lot of, this person doesn't care about themselves or their community. They just aren't willing to try. And it's actually really easy to get off drugs. Like, oh, a friend of mine did it. Didn't you see the Ray Charles biopic? Like, it was super easy for him. Why doesn't everyone do this? And they'll cherry pick things. And I feel like substance use and recovery and recurrence of use is so hugely plagued by survivorship bias. The people that have the easiest time, or easiest probably is a really unfair word, the people that are most successful at maybe getting to a place in their life that has a better relationship with substances, where they're able to reduce the harms of their use, maybe they're able to abstain altogether if that's their goal. Those are the people we hear about the most over and over again. If your loved one ends up, dying of an overdose, or ends up never getting to a place where they have a more reduced harm relationship with substances, like was mentioned just a minute ago. Maybe hepatitis C enters the picture. Maybe that's what ends up, ending their life. We don't hear about those people. Those are the people that families are embarrassed to talk about. Those are the people who slip and fall in the shower. Those are the people who their deaths are chalked up to cardiac arrest. So it's, we have a really big problem with hiding the true extent of what's going on here. So that the cases that are picked up and held up feel common when they're actually quite rare. Or if they are relatively common, it probably has a lot to do with other circumstances as discussed, like access to ample resources being the big one, access to whiteness, not having to deal with that over and over again. So I feel like survivorship bias and that just kind of tilting our entire understanding and view of substance use and what the reality is of navigating it, what the reality is of navigating disordered use, what the reality is of navigating access to care, access to clean syringes, access to clean stems, whatever it may be, is hugely skewed in the public eye. And something that Carl Hart wrote about in his recent book, Healthcare or Drug Use for Grownups, was how the media also has a role to play, because a story of someone who just kind of uses some substances and goes on with their day and lives a very normal, typical life isn't nearly as great at bringing in viewers as someone who has like an incredibly chaotic and dramatic relationship with drugs. That's why we see things like intervention being wildly popular. Like I would give my left arm to just have a sitcom episode of a character that just like smokes some heroin and then goes to their job, and it's just treated like having a cup of coffee. And it's not, the be all end all of their character. It's not going to be their ultimate downfall. It's just something that they do. So I feel like we have, and I'm not sure what the solution is, but I feel like we have a very big mountain ahead of us, and that's perception, because perception rules. It's what drives votes. It's what drives political action. And everyone overuses the meme from Parks and Rec, right? That like people hate facts and science. Well, it's unfortunately very true. But even then, we have issues with getting adequate data. We have issues with getting unbiased data, clear looks at things. There are even people who will argue that you shouldn't look at certain things. I was just, looking at a thread from Stephen Cortez this morning, where he was talking about how people have argued with him that he shouldn't even research suicide among people who have been forcibly tapered from opioids. Like you shouldn't even look at the question. So I think as long as we have this issue where we like the clean, biased narrative that's very, very common, any effort to push back against it is going to be seen as a problem. And until we get past that and we get to a point where we're all willing to be radically empathetic and loving of one another, and perhaps step back and see the larger picture and see how it's been colored and cherry picked for us, it's going to be really hard to move forward. So we just have to keep pushing and keep working together, I think. But it's a nasty one for sure.
Definitely. Definitely. So I'm going to ask this question for y'all to jump on in for one of our discussion prompts. But how did you first learn about harm reduction, and how did you work to change your thinking or mindset? How did you first learn about harm reduction? And did you have to change your thinking or your mindset, or was it something that you were easily going, that makes so much sense?
I actually learned about harm reduction through the Drug Policy Alliance, and Glenn Lyman, the state director, hired me as a consultant to advocate for safe consumption sites. And when she first told me about the assignment, I asked her, so I said, you want me to advocate for a safe place for people to shoot heroin? It took me a little while to wrap my head around that. And as a result of working with her and her educating me on it, I moved into addiction treatment and started working for Kassandra treatment centers. And I did some drug user advocacy on Skid Row with Drug Policy Alliance was part of one of the sponsors for that also, and the California Harm Reduction Coalition.
Thank you.
This is kind of one of my favorite stories when I try to get people to understand what harm reduction is and how non-threatening it really is. So I learned about it very accidentally. So as was mentioned earlier, I'm a paramedic, and I spent the bulk of my career in the emergency department. And we, every single shift over and over and over again, we would have lots of people brought in with an opioid overdose that had been given naloxone in the field, like on the ambulance, and they may be coming in feeling really wretched, or perhaps they were brought in quickly by a friend and they would be, not breathing and cold and clammy, and we would give them naloxone and they would wake back up. But it was always it was a dramatic patient. It was scary. They were in bad shape. And one day we had a patient that was brought in by EMS, and it was called in as a drug overdose. And this patient was just sitting up and talking and texting and looked very calm, and kind of asked, oh, what happened here? And they're like, oh, well, their friends gave them naloxone before we even got there. And I just said, how? Like, how did that happen? Like, how did they even get that? They're like, I don't know. And so I started looking into it, and I realized where it was coming from. It was the Austin Harm Reduction Coalition. And I just spent some time on their site kind of reading a little bit about this, and it just kind of hit me like a bolt. I was like, this is the most obvious thing. Like, why aren't we doing this everywhere? I was like, this person was so much better. They were in great shape. They were fine. They were able to go home just like an hour later. Their brain hadn't been harmed by not breathing. They, were given a small dose of it because their friends knew how to do that. So they weren't vomiting, they weren't, chills. They hadn't been pushed into precipitated withdrawal. It was absolutely the best outcome that I could have hoped for. And it was because of harm reduction, it was because of community, and it was because of that patient being able to choose that and set that out for themselves, and the harm reduction resources in the community were able to make that happen. So I think the problem was that I hadn't seen an alternative model. I hadn't even thought to think of it. And as soon as I did, it was just the most obvious answer. And it was just kind of a love story from there. I just kept running with it and wanted to learn as much as I can. So I do have some hope that there are more people out there that as soon as they see the power of it, that flips a switch for them. But that was my moment. Makes for a good story.
For me, it was my social work internship at Drug Policy Alliance. But I think, yeah, I didn't really think about drug policy before I started at Drug Policy Alliance, in that, well, I had family members who both sold and used drugs. I didn't think about the fact that someone was creating the laws to make it so. I think I always had they wouldn't do this if they were white kind of thinking, based on just being Black in America. But I think how I learned about drug policy in practice was that a lot of our campaigns that we were working on were built in conjunction with the Drug User Union in New York. And so working, tabling, communicating, riding on buses, doing elected official meetings with people who use drugs or who had used drugs or who were doing street outreach. And recognizing that the people that I was on the bus with at 8 o'clock in the morning going to Albany were sometimes the people that were under the Washington Heights Bridge, really showed dimensions that were not possible outside of the concept of harm reduction. And so it was honestly just by building deep, meaningful relationships with people who had more to gain on the work that I was working on, that really built my ability to see, right, and to recognize them as full participants in society, and not oh, like, you need to help them. Like, I'm not actually helping the drug user unions, right? Like, they're full participants. We're equal partners in that. We might not be seen that way. We might not be perceived that way, but I have to perceive it that way if I'm actually going to be a true harm reductionist. And so I learned harm reduction from Vocal New York.
Thank you. And just for my own little addition to that, so I benefited a lot from a family member who sold drugs. But at the same time, my family was very involved in church that would also take care of drug users. So my early memories of harm reduction, we didn't have a name for it. We just called it taking care of folks. You know, you knock on the door, someone knocks on the door and they need somewhere to stay, they stay. They need something to eat, they get something to eat. So I had been doing harm reduction for so long, but never knew what it was until I started doing abortion referral work. And then someone mentioned it, like, oh, this is harm reduction. I said, who? I'm sorry, what? And then, and actually doing that work in the South, teaching medical professionals how to offer compassionate abortion referrals is how I came to harm reduction work. And I'm here. So we have a question from the audience. And so anyone on the panel is free, of course, to respond. It says, I am a big supporter of harm reduction, but many systems, probation systems, the CPS, require complete abstinence. I want my clients to make the choices that are best for them, but they can't. Any suggestions for how to deal with that?
Well, as I mentioned earlier, I've had the same problem with providers and policy advocates that they say that they're harm reduction based, but they actually promote abstinence or will kick you out of their program if you do use. So that's a very, very tough question. And the only way to really deal with that, I know here in Los Angeles, we have a Department of Substance Use Disorder, SAPSI, and they have mandated that all of their providers maybe not get rid of abstinence space, but start leaning more towards tolerance and giving people a second chance if they do relapse. And as I also mentioned, some providers take advantage of that and just let their patients relapse over and over and over again without giving them any different, what I consider intensive case management. I think that's one thing that can help with adhering to abstinence-based policy is intensive case management.
One thing that we've had some luck with here in Austin has been just trying to find like just the one right person within the system who might be a sympathetic ear, and then just trying to tailor the argument to them. So one thing that we have here in Travis County, which includes Austin, we were able to support and promote naloxone take home from the Travis County Jail. And this took a lot of pushing back against some hesitation. The thing that really helped it was that it was starting to hit the news, the overdose rates going up and up and up in the community. And we were able to, and this feels really gross, but we were able to kind of leverage that concern and anxiety from policymakers and lawmakers and then present them with data as to why this would work. And it ended up helping. That plus being willing to stay with them and help them along the way. We wouldn't just suggest it and leave. Providing, wraparound support on the program. But unfortunately, a lot of times it's just trying to figure out what's gonna resonate with that community, what's gonna resonate with that office. Like, do you have an in there? Is there someone you can listen that you can talk to that might be able to promote some change? I have to tell you, there's not a great body of work out there about like what really works, especially with criminal justice and carceral context. There's just a lot of reticence and a lot of foot dragging. It's just something that I spend time staring at the ceiling over. But that's my best suggestion, is to come armed with lots of evidence about what works, but to tailor that to your audience and try to find the one champion that might help you. This isn't anything that I think is going to work in a really big top-down sweeping measure. It's got to be like office by office by office.
So I want to, we only have a few minutes left, so I just want to ask this. For folks that are interested in the harm reduction conversation, right, if they need more information, if they need more support, what's some action steps or what are some things they can do to join the conversation or to be more informed, to gather more information?
One thing I recommend is becoming an ambassador to Shatterproof. I'm an ambassador, and that's how I got hooked up into this conversation. So I will highly recommend that.
And I send people all the time to both NHRC and DPA. I think it's a really fantastic body of resources for both people that may be a little bit more experienced and complete newbies to the conversation. Especially if they're in a place where maybe there isn't a really well-organized harm reduction group locally. And that describes a lot of places in the South and Southwest. So if they don't have that, I think those two major resources, as well as Shatterproof, are great places to go to start educating and connecting with the right people. But then as much as possible, connecting with people doing the work locally. There's usually someone around, even if they can't advertise, even if they can't, set up a website or something, but to just do their best that they can and grow from there.
I would say if you are a person of African descent, we are organizing the Black Harm Reduction Network. And so that is a group of folks that are around the country that are of African descent, identify as Black, who are building like capacity and knowledge base around harm reduction, because there are so many people in the Black community that have been doing harm reduction, like Tamika said, that didn't know that it was called harm reduction or don't use that language. And so I think there are way more folks, Black folks, that are doing this work, that are trying to learn together and build strategies that can help us navigate drug policy and systematic racism.
And I'll add, the National Harm Reduction Coalition does have a training institute for folks if you're looking for basic harm reduction information and principles, as well as syringe service programs in your area. So just Google National Harm Reduction Coalition. We also have a national conference October 13th through the 16th in San Juan, Puerto Rico this year. So look us up.
I have a question for Kassandra, or I'd like to get in touch with this Black Harm Reduction Network. Can you put something in the chat or let me know what's up with that? Hook me up.
Take it away, Rachel.
Awesome. Thank you, guys. And I totally agree with that. All of the information, we're getting a lot of questions about different resources in the chat. So we'll be sure to follow up and get resources out to our attendees. With that, though, this does conclude our session on harm reduction and intersectional stigma. And thank you all so much for your thoughts and commentary this afternoon. We're so appreciative of your time. For our audience members, we will now be taking a 10-minute break before the second round of breakout sessions begin at 2:10 Eastern. Breakout session in exploring the roots of anti-stigma and anti-racism work will be occurring in this tab within the video stream, and just be sure to check out the other ones in case those are also of interest. As a reminder, these will all be recorded and sent out, and instructions for claiming CE credit will be provided at the conclusion of the summit. It's been a pleasure to host all of you for this session, and please enjoy the rest of the summit programming if your schedule allows, and thank you so much.